In the August 8th issue of JACC Interventions, a rather important topic, prognostic impact of chronic total occlusions. It is a report from SCAAR, we've talked about that before. It is the Swedish Coronary Angiography and Angioplasty Registry. And to do this, I'm talking with Dr. Elmir Omerovic, who is an MD and a PhD, who is from Sahlgrenska University Hospital in Gothenburg, Sweden. Now, this is a topic that's really quite interesting, and it's one that we haven't always had the best data on. So what were you trying to do with these 14,000 plus people who are in this particular registry?
Yeah, as you said, this is an important and difficult topic, the issue of chronic total occlusion and what is their prognostic role in patients that we treat on an everyday basis. So SCAAR, or Swedish Coronary Angioplasty and Angiography Registry, has been in Sweden active for many years, and all procedures that we do, we almost immediately report to our national registry. And then we ask ourselves how important are chronic total, how often they occur in our patients, and what is their prognostic impact. So we find out that in approximately 16 to 18% of all patients that have significant coronary artery disease, we will find also CTOs, or chronic total occlusions. We also find out that SCAAR contains the largest number of these patients. The previous studies until recently only reported in the perhaps hundreds of patients on different topics. So we found out that we have quite a substantial number, almost 14,500 patients that were.
And that's out of like 276,931 angiograms at 30 hospitals, so that's a lot.
That's a lot, yeah. And when we realize that, then we ask ourselves, what can we look in the similar, what other groups have done, and can we reproduce this data? Are there other interesting findings that our data will show?
So the data comes from between 2005 and 2012, so it's some of the most recent stuff is pretty recent.
Right.
What did you find?
So we found that some of the findings that we describe are confirmatory to the previous smaller studies, but some are new. For example, we find out a gradient of risk in different subpopulations. For example, if you are younger than 60 years old, and if you have STEMI, you belong to the highest risk group compared if you are elderly and you have a CTO when you have your stable angina. So we found the risk gradient both from younger having higher risk and elderly having lowest risk in one way. On the other way, we also found a gradient where the CTO has the smallest risk in patients with stable angina, then it increases unstable angina, non-STEMI, and the risk is highest in the STEMI patient. So by combining these two findings, we find out that the highest risk of CTO is if you have a younger patient of 60 and below that at the same time has a STEMI. So that's the major finding in our study.
So when do you intervene? That's one of the big questions that, do you do anything, you know it's there, or do you wait for something? What does your data say in terms of how do we handle this patient with a CTO?
So we haven't really looked in that question. We are this ongoing analysis of the data. We will be able to look in patients that have stable angina and that have been treated medically, conservatively, and we will compare this patient to patients that have been treated invasively, meaning with percutaneous coronary interventions. So we have a couple of thousand of patients that we can really compare medical treatment with PCI treatment. Until now, there were no such studies there. My colleagues, fellow researchers, have addressed the issue, as we did in this paper, comparing the groups that have both underwent PCI, but in one patient population, the PCI was unsuccessful, and the other group was successful. And when we compare these two groups, so we see that unsuccessful PCI in a patient with CTO is associated with higher risk compared to the successful. and then we need to continue this. The real issue is whether PCR compared to the optimal medical treatment gives similar or better result.
I mean, one would think that if someone is at high risk of an ACS, based on what you know now, if they have stable angina and don't appear to be at high risk for ACS right now, that might be one patient. But if you think somebody, because they have a high stress job, they haven't got their cholesterol under control, they have hypertension, that might be a person that you want to look at twice in terms of what are you going to do about now that you know there's a CTO there.
Right.
Can you say that based on this data? Because you connect ACS so tightly with that's high risk. If you have ACS and you already have a CTO, that's high risk.
Yeah. It is, but I think it's premature to draw that conclusion. I think we need to randomize clinical trials. Our data support that hypothesis, but we need to go and continue and address that issue you are mentioning now by means of properly randomized clinical trials. And there have been a couple of them. Some of them has been actually presented at last TCT meeting. It's called Explore trial, a small trial, 300 patients, with the endpoint being post-infarct remodeling, ventricular volume and ejection fraction. It didn't show primary endpoint was neutral when we compared the routine intervention in the patient with STEMI and having CTO. It didn't turn out to be a positive trial. So we need to redo this on a larger scale.
So what's your take-home message? Because you've got a lot of data in this paper.
Unlike the previous study, this is the largest one, and it supports to some extent previous findings. But what we found is that in patients with stable angina, the risk is almost, very little, additive risk. But perhaps if we are going to prioritize the studies we need in the near future, it should be focused on patients with acute coronary syndrome and simultaneously having CTOs. Those we need to address in a randomized manner and see where it leads us. And perhaps from the cost effectiveness aspect, those are the patients that we need to focus. Of course, there's also always a symptomatic indication even in patients with stable angina. But we are also interested about the prognostic impact of our intervention.
Exactly.
Can we save lives?
Well, the editorial comment that came along with this was written by David Kong and Magnus Oman, who I've known for many years. And they're talking about CTO, percutaneous coronary intervention and mortality, a hybrid approach to interpretation. So what they're referring to there is the fact that this is what you've found, and it really does seem to make it gives us some ideas of what we should be looking at next.
Right. That's right. I share that opinion.
Congratulations, by the way. This is a very large group of patients in, like I said, a difficult population, 14,000, almost 14,500. Yeah. That's some great work.
We are continuing every year. We are now continuing, to gather this information. So every year the CTO population is getting larger and larger, and we are following them longer and longer. And we are fine-tuning our registry with also having, as we call it, CTO module with numbers of variables that actually gives us information how we went to treat these lesions from the point of interventional cardiologist aspect.
Well, this is in the August 8th issue of the Journal of the American College of Cardiology, Cardiovascular Interventions. Please look at that. And that's both the paper by Dr. Omerovic as well as the editorial comment. For CardioSource World News, I'm Executive Editor Rick McGuire.